Well, let's take a look at some of those criticisms first of all. So, might there be some consideration for exemptions to be made for those with a limited income, pensioners, for example, as mentioned by these groups?
Okay, let's have a look at this. The policy is not blanket; it's only just beginning to roll forward. And each step we take, we will look at the science. First of all, the science and the benefit we gain from these products, and then how they fit into what we're doing. So, if I can take an example, such as the treatment of constipation. Now, for most people, that requires a small change in your diet, a bit more exercise and one or two other things, but that's fine. And if some people do occasionally need, as well advertised on TV, a laxative, but for some groups of patients, it will be essential that they continue to be able to access it. So for people who are on long-term opiates for treatment of chronic pain, they will still be able to access it because it's essential to manage their side effects. So the policy's already got nuance in it. Now, the other thing, of course, is that some of the groups we've talked about, of course, are the biggest beneficiaries from the system anyway. Mm-hmm. In other words, particularly the elderly, they're the biggest consumers of medicines by a long margin. And also, they're the people who benefit from us reinvesting our resources in treatments for cancer and long-term conditions such as Parkinson's disease and hypertension and hypercholesteremia and so on. So what we're trying to do is we're trying to use the same prism that we would use to look at a new medicine being put on, which is only available on prescription, added to our list of things going forward. We're looking at using the same prism to look at the things that could be bought over the counter, because we need to make sure we invest our money as effectively as possible to deliver the best healthcare outcomes for the community in Gibraltar. And we need to do that. And that sometimes means the science has moved from when these things were started, when patients were first put on them, and nowadays we'll see recommendations that we shouldn't be using them. So this is an evolutionary process. Mm-hmm. It's not a sort of guillotine that's just going to land on top of people. Oh. But I think what's important is people understand is it will all be done with thought. And the issue about impact on vulnerable groups will be part of that consideration.
Might we consider a blanket exemption for pensioners in particular?
Well, the pensioners are an interesting group, speaking as a pensioner, because I'm well over 60. Speaking as a pensioner, some of us can afford to do this. Some of us, my fellow pensioners, can't, and we have to accept that. But I think the issue then is we're still having to look at that care decision through the same prism. Back to my point, if the science is saying it's better for us to invest that money in treating your hypertension, I think is what the pensioners would want us to do, because that protects you from stroke and much more serious disease than some of these minor treatments are doing. So I think it's about refocusing the resources, not taking it away, but putting it to where it will deliver the best care for the patient.
Those resources would have already been invested in. This is not money that's being redirected. Those services you're talking about already were being spent on. So when we're talking about an estimated...
I think that's not correct, because the science keeps moving and we get new treatments every year. So I have got 2 requests this year for 2 patients, which will come to just shy of £500,000.
But we are talking about a shrinking of services, essentially. These are services that were available that are now not.
I think, no, I don't agree with you. What I think we're doing is refocusing those services to deliver better care where it will be more effective. We have to use our resources to deliver the best care possible to every patient. And every patient's condition is important to them, and I respect that. But what I think we've got to recognise is that the number of people over 60 is growing, and that age group, unfortunately, comes with a significant amount of morbidity attached to it. We are trying to manage that morbidity. Therefore, the demand for our services continues to expand, and will do probably for another 20 years. And what we have to do is to make sure that every cent we use, every penny we invest, is delivering best outcomes. So if I can prevent your stroke, I've achieved a lot. And if I have achieved that, maybe by disinvesting in a moisturising cream or something, then that to me is good investment.
It's not just moisturising creams. Some of these medicines, for example, nappy barrier creams, treatment for mouth ulcers,
nappy barrier creams
they hugely affect the quality of life for some citizens.
So I think all of that's got to be thought through. But I think the point I'm trying to make is that some of these things are of limited value. And when you do the same science and evaluation of their value to the community and to the individuals that are receiving them, I think people would rather prevent the stroke than worry about the nappy cream. And I think that's what we're trying to do. We're trying to redirect resources, which we already have, to achieve better outcomes. So this is about being able to take on the new medicines.
Okay. Well, thank you, Mr. Freestone. I think that's all we've got time for. I'm sure we could talk about this for much longer, and I'm sure we will.